Good evening, everyone. Welcome, and thank you so much for joining us for tonight's UMiami Health Talk. Am I too young to worry about colorectal cancer? A much anticipated talk tonight with so many of you joining us despite the weather. I'm health journalist Ileana Bravo, and I'll be your moderator for tonight's Health Talk presented by UHealth Virtual Clinics. We want you to know that UHealth's expert providers are ready to care for you in our facilities, virtually, wherever you are. And we also invite you to learn more about the measures we have in place to keep you safe, as well as your appointment scheduling options by visiting umiamihealth.org. Tonight, we're privileged to hear from three Sylvester Comprehensive Cancer Center experts, Dr. Daniel Sussman, Ms. Rachel Silva-Smith, and Dr. Sunil Amin. There will be a question and answer session at the end of the presentation with our experts. And though many of you have submitted questions in advance, you can still enter your questions during the webinar. Don't worry, there's time. Use the anonymous Q&A feature at the bottom of your Zoom screen. Take a moment to locate that, and you enter the questions as you think of them, and we'll prep them for our panelists to address at the end. In addition, our experts are going to be asking you some questions during their talk, so be prepared to respond and participate with those couple of poll questions. So now I'm pleased to introduce our first speaker of the evening, Dr. Daniel Sussman, a gastroenterologist and professor of clinical medicine in digestive and liver diseases at the University of Miami Miller School of Medicine. He's board certified in internal medicine and gastroenterology and subspecializes in heritable cancer syndromes of the gastrointestinal tract and colorectal cancer screening. His research focuses on improving strategies to identify families with heritable GI cancer syndromes, improving methods to identify and prevent colorectal cancer, identifying and clarifying the role of molecular markers of GI malignancy, and developing a repository for patients with GI tract neoplasia. Please help me welcome Dr. Sussman. Make sure you unmute yourself, Dr. Sussman, and we're ready to go.
So good evening, everybody. Thanks to Ileana for moderating. Thank you to UHealth for putting this together. And most importantly, thank you to all of you in the audience for taking time out of your busy schedules to listen to us. So I figured we'll jump right into it. And I wanted to present to you the topic of when should colorectal cancer screening begin. And the reason why this topic is important is there's been some very recent changes at the age at which colorectal cancer screening is supposed to be initiated. Traditionally, we used to tell the average person walking the street that they should begin screening for colorectal cancer at age 50. And now we're rounding that number down to 45 for a variety of reasons that we'll get into during this webinar. So for starters, what is cancer? So cancers occur anytime a cell in the body starts to divide or replicate out of control. And that's certainly the case for cells in the colon, that when they divide, they can start to grow out of control. When that happens, the normal cells that line the colon can begin to grow into polyps, which are these little bumps on the wall that you can see in the cartoon at the bottom of your screen. And as these polyps grow, they have the potential to turn angry in nature. And as they divide, they can start to invade and can turn into cancers, consuming the colon itself, and eventually can take over and grow out of control. So now that we know what colorectal cancer is, I thought I'd provide you some eye-opening statistics. So first of all, why is colorectal cancer important to speak about? It's the third most common cancer in both men and women. And despite how common it is, the majority of the cases of colorectal cancer are actually preventable. To put these numbers in a different light, and this is usually the numbers that are a bit more eye-opening, for those individuals who don't undergo colorectal cancer screening, 1 in 23 men and 1 in 25 women will go on to develop colorectal cancer. Those numbers are staggeringly high. And of the 150,000 people who are newly diagnosed with colorectal cancer every year there's also more than 50,000 people who die of the disease. And as we'll touch on a little bit later during this first part of the webinar, it seems like colorectal cancers are happening at younger and younger ages. As an example of that, somebody who was born around 1990 has about 4 times the risk of somebody born around 1950 of going on to develop and getting diagnosed with rectal cancer. And we'll touch on this topic quite a bit during the webinar. So now that we know what colorectal cancer is and we know how common it is, what are the risk factors for it? Why do colorectal cancers happen in the first place? Well, most importantly, colorectal cancer is a disease of age. The older somebody's colon gets and the older the cells in their colon get, the more likely they are to divide out of control and develop into polyps and ultimately into cancer. And we know that individuals who have a personal history of colorectal polyps, those little growths in the colon, or a family history of polyps and cancers of the colon are much more likely themselves to develop colorectal cancer over time. In addition, there's a lot of lifestyle factors or modifiable risk factors that contribute to colorectal cancer as well. Namely, obesity is an important one. So the more somebody weighs, the more likely they are to develop colorectal cancer. And this happens in gradation. So people who are overweight have a slightly increased risk, and people who are significantly obese or morbidly obese have a much higher risk of colorectal cancer than others. Leading a sedentary life or physical inactivity is another major contributor to colorectal cancer, as are other comorbidities like diabetes. When I mention diabetes, specifically, we're talking about people who have diabetes that's poorly controlled. And so there's some hormonal effects that happen in our bodies when our sugars, our blood glucose levels stay out of control for prolonged periods of time. And those changes themselves are what actually induce these polyps to grow and eventually turn into cancers. Diet is actually also of paramount importance when we're talking about colorectal cancer. Those individuals who eat large amounts over their lifetime of red meats have a much higher colorectal cancer risk than people who don't eat red meats. And it's shocking when you look into the subcategories of what is a red meat, that processed red meats are this subcategory of food stuff or food type that has a massively increased risk of colorectal cancer over time. Specifically, I'm talking about any meats that might come wrapped in plastic that you might buy from a deli counter. So that would be, hot dogs, bologna, salami, or chorizos and sausages and bacon and things in that spectrum. So those are major foods to avoid if you can. Excessive alcohol use and tobacco use are also contributors to colorectal cancer. And in some cases, race can contribute as well. What races in particular? Well, there's certain individuals, those of Black ancestry, and even some populations of indigenous people that live in a variety of parts of the world have very increased risks of colorectal cancer as well. And I'm not going to say too much about the last one, which is genes there. That one is of vital importance for colorectal cancer risk, genes that you might be born with. And abnormalities of those genes can majorly contribute to colorectal cancer risk, particularly at young ages. And Rachel Silva-Smith is going to do an outstanding job at explaining that risk to you coming next. So when somebody does have colorectal cancer, what are some of the warning signs or symptoms they might have? Rectal bleeding would be a major red flag. Unexplained and undesired and uncontrolled weight loss are also of concern, particularly if somebody's over the age of 45. Severe constipation that's not controllable with medications, or if you've been told that you have anemia from low iron levels, so a low blood count from low iron levels. These are all warning signs and symptoms. Now, one of the important take-home messages with colorectal cancer is that for somebody to develop warning signs and symptoms, that's much more likely to happen when they have a cancer that's already at an advanced stage. The majority of people who have colon polyps or very early colon cancers, meaning ones that are very easy to cure, most of those people have no symptoms at all. And that's the major reason why we recommend that everybody who hits a certain age gets colorectal cancer screening, regardless of whether or not they're having symptoms. So I don't want you guys to get dizzy by looking at these graphs here. I'm going to walk you through them very carefully. But the major point I want to take home here is that if you wait till you get symptoms, such as weight loss, rectal bleeding, or iron deficiency anemia, if you do have colorectal cancer, you're less likely to be easily cured. So the earlier we find a cancer, or the earlier we find a growth in the colon like a polyp, much easier it is to treat and get rid of and fix. And if somebody waits until they have symptoms to go get checked out, they're less likely of getting cured very easily by the treatments that we have at hand. Having said all of these scary figures and facts and figures, the important thing to take home here is that actually colorectal cancer is largely preventable. It's estimated that somewhere near 90% of colorectal cancers are completely avoidable. And completely avoidable means that when folks such as yourself partake of colorectal cancer screening at the appropriate age, these cancers are usually very curable or entirely preventable altogether, meaning that if we identify tumors before they grow into cancers, they can be cured at colonoscopy. So what are some of the different colorectal cancer screening modalities that we have at our disposal? These can generally be categorized in different ways. We can think of them as those that happen by procedure and those that are stool-based tests. Those that are procedures are ones that you may have heard of, known as sigmoidoscopies, colonoscopies, or sometimes even CT scans. And for these tests, particularly the colonoscopy and sigmoidoscopy, a camera on a flexible tube is actually inserted in the rectum. And we go into the colon looking for growths. One of the important and valuable features of a colonoscopy that will be touched on a lot by Sunil Amin at the bottom of our hour is that when we do find these growths in the colon, they're actually quite curable at colonoscopy. And the majority of people who have things growing in their colon that are at risk for turning into cancer in the future can be cured by just having the colonoscopy procedure itself. So procedures is one major category of these colorectal cancer screening tests. On a separate note is these stool-based screening tests. And so there's tests that you can do in the comfort of your home, where you poop in a collection device and send it off to a laboratory. And based on the tests that are done, if there's abnormal results that get flagged or the presence of microscopic amounts of blood in the stool, people who have an abnormal stool test result get triaged to have a colonoscopy to find out why there's blood in the stool or other molecular abnormalities. And then if it's negative, those people can just keep having stool testing throughout their lives. And both of these different modalities and approaches to colorectal cancer testing work. The particular stool test that you see in the picture here is the collection device that comes with the Cologuard test. And with this test, there's this little plastic device that you put over your toilet seat. You put this white collection bucket inside the plastic device, and you go about your business in the comfort of your home. You close it off and cap it off, and the FedEx man comes and picks it up from your home. And then you get a result in the mail several days later telling you whether you have an abnormal result or not. Again, if it's abnormal, you go on to have a colonoscopy. And if it's normal, you can keep doing stool testing periodically. Now, I mentioned that colonoscopy has value in that if growths are found in the colon, you can actually be cured during that procedure. And so a colonoscopy is quite capable at removing these small bumps on the colon, these large bumps on the colon, and even these ones that are listed as precancerous polyp. And there's been major advances in the past 5 to 10 years alone that Dr. Amin is going to get into that makes almost every growth on this screen curable or fixable by a colonoscopy. And only when you have a cancer that's invading the wall of the colon in this day and age are people required to kind of go on to surgery to try to achieve a cure. And so sometimes people, when they hear the word cancer, they get this defeatist attitude and they don't want to know if they have a growth in their colon or a cancer because they have this fatalistic approach because they've seen family members have bad times with cancer in the past. But colorectal cancer doesn't need to be that way. And one of the major take-home messages here is that if you find a cancer, it can be cured at colonoscopy, or it can be very curable with the interventions that are at our disposal after a colonoscopy. Now, I think I've spent a lot of time now selling you on the value of colorectal cancer screening. What I'd like to show to you here is if you direct your eyes to the years between 1980 and 1990 on this graph at the bottom, and look up at the green, purple, red, and blue lines above you, you'll see a sharp downward deflection in the incidence and mortality from colorectal cancer for both men and women. And so this is a feel-good story for preventive care and screening in general, is that those years between 1980 and 1990 is when colonoscopy came into existence. And in the years after it came into existence, that's where we see this sharp plummet in the incidence and mortality from colorectal cancer. And it plummets even more once people started frequently using stool tests to screen for colorectal cancer as well. Now, this is a phenomenal feel-good story for the field of medicine and for humanity overall. But we've begun to notice over the past 5 to 6 years that if we break down these numbers by different age groups, not everybody's the same. And even though colorectal cancer is dropping precipitously in people over the age of 50 because of screening tests, if we look at younger individuals, so that those that are 49 and younger, the rate of colorectal cancer is actually on the rise. Now, nobody really knows why that's happening. There's a lot of potential environmental triggers and reasons why that might be happening. And the prevailing theory right now that's in vogue is that it's actually obesity and a sedentary lifestyle over a period of many decades that's contributing to that. But in stark honesty, the field of medicine is not certain on that yet. This is just a little bit more information to prove to you that people are getting colorectal cancer at younger ages. I mentioned to you earlier that people who were born 1990 or later, their risk of colorectal cancer is actually rapidly increasing, especially as compared to those that are in these older age groups. And it's not only just by age of birth, it also happens by year of diagnosis. And let me say that a little bit differently, that if you happen to be in the 50 to 85 age range, your likelihood of being diagnosed with colorectal cancer is going down over time when you partake in these stool-based or colonoscopy-based tests. But for people who are under the age of 50 who previously were not eligible to undergo colorectal cancer screening, the rate of being diagnosed with these cancers is increasing over time. Now, it's fortunate that people who are in these 20 to 39-year age ranges, their rate of colorectal cancer is still acceptably low. But the rate for people that are over the age of 39 and more specifically over the age of 45 is not acceptably low. And that's why we're beginning to offer colorectal cancer screening to people in those younger age groups. So it turns out that 45 is the new 50. And so this year and in 2021, all of our major colorectal cancer screening societies are now recommending screening begin at age 45 for those individuals who are considered average risk. Average risk means that you have no symptoms. Average risk that means you don't have relatives with colorectal cancer. And average risk means that you don't have a personal history of a cancer-related diagnosis. Rachel will go into a little bit more detail about some other risk factors that might require you to have colorectal cancer screening at ages even younger than 45. For those of you who are worried, we all hear horror stories about colonoscopy, and frankly, even the thought of having a colonoscopy is off-putting. There's nothing that's really desirable about walking into a procedure area, getting sedated, having people stand around you in white coats and having a procedure done. But in actuality, whenever you talk to people after a colonoscopy is done, they'll always tell you that the bark is worse than its bite. They'll tell you that they woke up and they didn't feel anything. They'll tell you that they don't remember having anything done to them. And they tell you that probably they're going to tell all their friends to go out and get it done because they spent more time worrying about it than actually being bothered by the procedure itself. And I'd like to thank you all for listening to me. And without any further ado, I'll turn it back over to Ileana.
Thank you, Dr. Sussman. And our Q&A box is active tonight. There are lots of questions coming about so many of the topics that you've already touched upon, and your colleagues are going to do more of that. So just be patient, folks. We're going to have an opportunity to do that session coming up soon. So let's introduce our next speaker, Ms. Rachel Silva-Smith, a cancer genetics counselor with a subspecialty in hereditary cancers in the Digestive and Liver Diseases Division at Sylvester Comprehensive Cancer Center at the University of Miami Health System. She's board certified by the American Board of Genetic Counseling, and her mission is to empower patients with information about hereditary cancer syndromes, to explain genetic test results, and to clarify misconceptions about cancer genetics. I'm going to introduce Ms. Silva-Smith, and she is ready to poll you. So get ready with your answer to her first question. Take it away.
Thank you very much for that introduction. And thank you so much for having me tonight to talk about this topic that I think is really important. So the title of my presentation is colorectal cancer hereditary, and is there a test for that? So I'll get started first with a poll question to get a sense from the audience, how many of you are aware that there is genetic testing available for colon cancer risk? So did you know that genetic testing for colon cancer risk is available? Yes or no? And I'll give you a couple of seconds to think about that. Okay, so it's kind of split 50-50. I wasn't really sure what to expect. But hopefully this talk will help you all get a better understanding of genetic testing that is indeed available for colon cancer risk. So what I'll be talking about today I'll go over the risk factors that Dr. Sussman already mentioned, but my main focus will be the genetic risk factors. Genetic risk factors, what our genes can tell us about your risk to develop colon cancer, who should consider genetic testing, how to go about getting that type of testing, and what to do if you find out that you have a high predisposition to developing colon cancer. So I'll just go through the risk factors quickly. It's always worth reiterating the risk factors because these are really important things to keep in mind. So one of the most important risk factors is age. As we get older, the risk of colon cancer increases, but then of course we have some lifestyle risk factors like high BMI, inactivity or a sedentary lifestyle, a diet that is high in red meat or processed meat, a diet that is low in fiber or high in fat, high alcohol consumption, tobacco use. And then besides for lifestyle risk factors, there are also inflammatory bowel diseases like ulcerative colitis and Crohn's disease, which are also risk factors for colon cancer. And then of course, family history, just having a family history of colon cancer does increase your own risk of colon cancer. But what I'll be focusing on is the genetic risk or hereditary risk. So if we look at all cases of colon cancer, we know that about 5 to 10% of those cases are due to a hereditary problem. And I'll be using the word hereditary and genetics interchangeably. So to explain a little bit more what we mean by hereditary risk is due to abnormalities in the genetic code that can make the genes stop working properly or not work at all. So this here is a strand of DNA. But another way to picture the genetic code is to actually think about the letters that make up the genetic code, A, C, T, and G. And we know what the normal genetic code is supposed to be. So an abnormality can be something as simple as a single letter change. Sometimes it's a different abnormality, but sometimes it's just one letter that's different. So instead of a C, you might have a G somewhere. And that abnormality can make the gene not work properly. And that abnormality can also be passed down through the generations. And this is something that we can test for with genetic testing. So who should be considering genetic testing? So I'll go through some of the red flags that make us think about genetic testing. One of the biggest red flags is anytime we see cancers happening at young ages. So colon cancer under age 50 should make us think about offering genetic testing. Because as we said, colon cancer increases as we get older. It's not as common to see colon cancers happening young. So that's a big red flag. Another important red flag is when we see multiple cases of colon cancer in the family. Anytime we see 3 cases or more, that's a red flag. And it's not just colon cancer. Some genetic abnormalities can predispose to different types of cancers. So if we see multiple related types of cancers in the family, that might also make us think of genetic testing. And of course, if we see certain patterns in the family, like we see multiple generations affected by cancer, a grandparent, parent, and child, all with colon cancer, that makes us think that there's something that's being passed down in the family that is genetic. And anytime we see somebody that has developed multiple colon polyps, especially the precancerous type, when they have 10 or more polyps, that's when we start to think about offering genetic testing. So when these red flags are identified in a person or in a family, we see these patients in our multidisciplinary clinic. It's a GI genetics clinic. So in this clinic, you meet with Dr. Sussman and somebody like myself, one of the genetic counselors. And we see patients either in person or through telehealth. So it's as convenient as possible. And our main focus is going to be asking you about your cancer screening history. So any colonoscopies or upper endoscopies that you've had to figure out if you have a history of colon polyps. And of course, we'll ask you about any personal cancer history that you might have. But then we'll also spend a lot of time focusing on family history. So we'll draw a diagram like this, where we map out your family history. We call this a pedigree, and we shade in anyone who has had polyps or cancer to kind of get an idea of the pattern that is in the family, to see if it's likely that there might be a genetic problem in the family. So if after that discussion, we see that genetic testing might be necessary, then we would collect the sample and send it off to a lab. So a lot of people don't know exactly what is genetic testing, what's actually done to obtain genetic material and get the testing done. So that's my next poll question. How do you think genetic testing for cancer risk is typically performed? Is it with a blood sample, a bone marrow biopsy, a saliva sample, or a urine sample?
Now let's see how many people are paying close attention, because this is one that I'm not sure any of us would know in the lay public.
A lot of people don't know, and a lot of people think it might be very invasive testing. So I think it's important for people to know what it is.
Let's see how they did.
Okay, so most people think it's a blood sample. That's correct. Bone marrow biopsy is not something that we would do in our clinic for genetic testing purposes. But this is kind of a trick question, because actually, if you answered blood sample or saliva sample, those are both correct. So it's not with a bone marrow biopsy and it's not with a urine sample. But with blood or saliva, we can the lab will extract DNA from those samples and run the genetic analysis. So it's actually really not a very invasive test at all, very simple. So once your blood or saliva sample is collected, either in person or it can actually be done remotely, that sample is shipped off to the lab. And I put all these acronyms here on the screen, not so that you can memorize the names of different genes, but just so that you can get an idea that it's not one colon cancer gene. There's many different genes that we know that are linked with hereditary colon cancer. And every gene is different. Some genes are associated with a very, very high lifetime risk of colon cancer, approaching 100%, and others are a lot lower. The risk may only be 10%. So of course, we're going to offer different recommendations and different screening plans depending on which gene might come back positive. It's not just, high risk of colon cancer. It's not all the same for everyone. And some genes are linked with only colon cancer, and others are linked with other cancer risks as well. So results of genetic testing usually take about 2 to 3 weeks. And once we get your results, if anything comes up positive, we see you in clinic to discuss what risks you might have and what the recommendations are. So just to illustrate this point a little bit more about how different conditions can be different from one another. In this table, I'm showing 2 of the classic hereditary colorectal cancer syndromes. One is called Lynch syndrome, and the other one is called familial adenomatous polyposis, or FAP for short. You can see that the colon cancer risk is very different. For FAP, the risk approaches 100%. Whereas for Lynch syndrome, there are different forms of Lynch syndrome, and the risk may be only as high as 9%, and with other forms, it may be closer to 60%. So it's quite different, and our recommendations would differ for these conditions. Also, the average age of diagnosis is different. For Lynch syndrome, since there's many different forms of Lynch syndrome, we can see an average age of diagnosis somewhere in the 40s to 60s. And for FAP, the average age at colon cancer diagnosis is 39. Other risks that we see in Lynch syndrome, but that we don't necessarily see in other conditions, are cancer of the uterus, ovaries, stomach, small intestine, pancreas, and others. And something that's very characteristic of FAP is that we see that people develop hundreds to thousands of polyps in the colon starting in the teenage years, which we don't see in other conditions. So all that to say that not all colon cancer syndromes are exactly the same. And it's important to pinpoint exactly what is the cancer syndrome that might be present in the family. So what do you do if your genetic testing shows that you have a high risk of colon cancer? Well, one of the most important things is that we often recommend starting colonoscopies at earlier ages, earlier than 45, because like I showed you in the previous slide, sometimes colon polyps can start developing in the teenage years, in which case in FAP, we actually start recommending colonoscopy in childhood. And in Lynch syndrome, we start recommending colonoscopies in the early 20s. The goal of that is to try to catch a cancer as early as possible, not wait until 45, where cancer risk is already quite high. More frequent colonoscopies are also usually recommended, and that again differs by condition. So with some genetic conditions, we may recommend colonoscopies as frequently as once a year, and with other conditions, it may be every 5 years. But usually it'll be more frequent than in the general population, where it's every 10 years. And again, the goal is to catch a cancer as early as possible, because in these people that are at higher risk, the progression from polyp to cancer can happen a lot quicker. And depending on which gene has the abnormality, we may be recommending additional screening or preventative options. For example, that condition that I mentioned, Lynch syndrome, which is linked with the risk of gynecologic cancers, we may recommend a preventative hysterectomy to really reduce the risk of uterine cancer. Or there may be screenings for other organs. So depending on which gene is affected, we would set you up with a plan to try to prevent cancers or catch them as early as possible. Now, what about relatives? If there's a genetic condition that is found in the family, what impact does this have on family members? So to go back to the pedigree that I showed earlier, these two people that are shaded in have colon cancer, and they both underwent genetic testing and were confirmed to be positive for Lynch syndrome. So now we have figured out why there's colon cancer in this family. And that's very valuable, because if this other relative, this other sibling in the family also tests positive for Lynch syndrome, we can set him up with screening at a much younger age than normal and prevent colon cancer and possibly other cancers as well. And it's also very valuable to the other family members who might test negative for Lynch syndrome, because they can be reassured that their risk of colon cancer is probably somewhere close to the average population risk, and they don't need to be over-screened and have all that anxiety about a high cancer risk. So genetic testing is valuable for the individual, but also for their relatives. So in summary, about 5 to 10% of colon cancer is hereditary. Some of the important red flags are anytime we see early cancers, multiple relatives with cancer and multiple generations with cancer, and people who have developed many precancerous colon polyps. Genetic testing can identify people at high risk, and then we can use that information to personalize screening. And if I can leave you with one important message that is going to be reiterated many times tonight, is that colon cancer is really one of the most preventable cancers. So it's important to find out if you're at higher risk so that we can personalize your screening. Thank you very much.
Thank you very much, Ms. Silva-Smith. Very important information, and I think eye-opening for a lot of us who didn't realize the genetic components. So now let's introduce our final presenter of the evening before we open it up for questions. And thank you so much for being so active in the question and answer button, because there were wonderful questions being asked. Dr. Sunil Amin, a gastroenterologist, specifically an interventional endoscopist. He's board certified in both the US and Canada and internal medicine and gastroenterology, and his areas of interest are the most advanced colonoscopy techniques, which many times help avoid the need for surgery. His research focuses on using large databases to study pancreatic cancer epidemiology on a population-based level. Please help me welcome Dr. Amin. It's all yours, Dr. Amin. Make sure you unmute.
Thanks, Liliana. Thanks again for having me tonight and for giving me the chance to talk to you about some of the new techniques that we're able to offer you here at the University of Miami in terms of removing colon polyps, which you've heard so much about tonight. I'm going to start with a schematic here of a standard polypectomy, and this is a procedure that we use when we find a polyp in your colon. It's fairly simple, and it's performed probably similar to how you'd imagine it being performed. We use what's called a snare, and we, in a sense, lasso the polyp, which you can see here kind of on a stalk. And we close the snare, and we just kind of cut it off, and we remove it, and we send it to the lab. And this is what the majority of colon polyps look like. And this simple procedure that takes just about a couple minutes is adequate for the majority of polyps found here in colonoscopy. The idea when we do a colonoscopy is that we find them at this stage, because it takes several years for this small polyp, as Dr. Sussman showed, to turn into a frank cancer. So oftentimes, though, we may find polyps that are too large or complicated to remove with the standard polypectomy, as I showed in the last slide. And this is where advanced endoscopic resection comes in. And that means that there are ways that we can use a colonoscope and during your colonoscopy, remove these polyps to prevent you from having unnecessary surgery. You'd be surprised that even in today's day and age, in 2022, the amount of polyps that are referred to colorectal surgeons for removal that we can actually remove just by doing another colonoscopy using some advanced techniques. And all of our endoscopists or advanced endoscopists here at the University of Miami are trained in these techniques. So I'm going to focus briefly on three methods here, just to kind of give you a sense of some of the procedures that we can perform. The first is called endoscopic mucosal resection, or EMR for short. The second is called endoscopic submucosal dissection, or ESD for short. And the last is called endoscopic full thickness resection, or EFTR. I don't want to bog you down into the details, but I'll hopefully give you a sense of which procedures may be appropriate in which settings. So the first is called endoscopic mucosal resection, or EMR. And what this involves, and I'll show you a schematic on the next slide, is lifting up the polyp, because oftentimes instead of being on a nice stalk, some polyps are kind of carpet-like and they're flat. So we lift it using an injection to bring it away from the wall of the colon, and then we use our snare like I showed you in the first slide to remove it. And we can remove polyps that are less than 3 centimeters in one piece, and larger ones may need to be removed in multiple pieces, though at the same session. There are certain polyps that are not amenable to this procedure, and I'll discuss how we deal with those in a few slides. This is what it looks like. You can see the colonoscope here, and there's a little needle coming out, and we inject a little bit into the wall of the colon to allow the polyp to be lassoed with the snare, and then we remove it similar to the schematic I showed you. Now, this technique is widely available. However, you do need to have some degree of expertise to perform it. The next technique, called endoscopic submucosal dissection, is not widely available, and it's only really available at a few expert centers such as ours. And this allows resection of large or fibrotic polyps, which means they may be scarred down, all in one piece. And that's the major difference from the last technique, is that we can remove even very large polyps all in one piece. And that's important because then we can send it to the lab as a large specimen, and the pathology doctors can tell us if there's any evidence of cancer in a much more reliable way than had it been submitted to them in multiple different pieces. So this is ideal for polyps that are not amenable to the last procedure called EMR. If they're large, if they have cancer in them, as Dr. Sussman showed, the progression from a small polyp to a cancer right before the last step, if they have a small amount of cancer, and then we can cure them through this method. Or if there's some residual polyp from a prior resection, and it's just kind of grown back. Again, this requires specialized training expertise. This is a schematic of what this looks like. Compared to the last procedure, the EMR, what we do here is we essentially perform a circumferential or a circular incision around the polyp using a special knife designed to work through the colonoscope. And we remove the polyp by kind of dissecting it away from the wall of the colon. And so essentially we're performing a surgery through the colonoscope. these procedures often take several hours to do. Lastly, EFTR, or endoscopic full thickness resection, allows us to remove polyps that are conventionally unable to be removed by colonoscopy because they don't lift. And by lift, I mean when we do that injection I showed you, which is a key part of the last two procedures to lift it off the wall, some polyps may not lift because they're either scarred down from prior attempts to remove them, or they may contain some early cancer, which causes fibrosis or scarring. And so this technique allows us to remove actually the polyp plus the entire wall of the colon. And of course, we close it up at the same time, and you don't feel that, but that allows us to really take deep polyps and remove them, because the way polyps grow is they start off in what we call the lumen of the colon, and they grow outwards towards the wall. So by removing the whole wall, we can be sure we remove the polyp that's gone pretty deep in terms of how far it's grown. This is what it looks like. The colonoscope here has a plastic sheath over it, and a cap here. And there's some forceps that we use to pull the polyp into the cap, and then we remove it that way. I want to finish with a couple case presentations of situations where we've been able to save patients from surgery by simply performing more advanced colonoscopies. And perhaps these might resonate with you from personal experience or family members or friends. And so the first is a 58-year-old gentleman who underwent a screening colonoscopy, and he was found to have a 3-centimeter polyp in his ascending colon, which is the first part of his colon, at an outside institution. And the doctor who performed that colonoscopy kind of cut the top of the polyp off, but didn't remove the whole thing. And he felt like it would be too difficult to remove through a colonoscopy. And so he sent the patient to a surgeon to remove half of his colon. And the patient, being an educated gentleman that he was, decided to seek a second opinion at University of Miami. And he looked up to see which doctors perform these advanced techniques. And he came to us, and we were able to remove his polyp successfully using the first technique I showed, the EMR technique, and we saved him a surgery. So he was very happy with that outcome. The second case is a 40-year-old gentleman who had a family history of colon cancer, and he'd been having some intermittent rectal bleeding, and he was found to have a large 5-centimeter polyp in the rectum, which is the end of the colon. And the biopsies performed showed that this was an advanced adenoma. So that means this was a polyp that was on its way to a cancer, but we didn't have evidence at that point in time that this was a frank cancer, in which case we would have had to send him to surgery. But because it was almost a cancer, we decided to try and remove it using an endoscopic submucosal dissection, which is the second procedure I talked about. And we were able to remove the entire 5-centimeter polyp in one piece. And the advantage of that was we could send the whole thing to the lab, and the pathologist actually said it did show early cancer. However, the colonoscopy was able to remove the polyp with what we call negative margins, so that the entire polyp was removed, and we could really see that on the pathology. And so after we met with our multidisciplinary team of experts here at the University of Miami, including oncologists and surgeons, we decided to give the patient the treatment for cancer, which was radiation and chemotherapy, but to not have him do a surgery. And because the surgery would involve having an ostomy bag, and that was something he was very against given his lifestyle, and obviously it's a life-changing situation if that happens to you. So we decided to do that instead, and we've been surveying him, and he's been doing great. And I think we may have cured him just with this advanced technique. So that was one of the real success stories, and just an example of how we can perhaps do things a little out of the box here at the University of Miami that may save you surgery. So in conclusion, most large non-cancerous polyps can be removed endoscopically without surgery. EMR, EFTR, and ESD are all advanced resection techniques that can be used to remove difficult polyps. And the University of Miami physicians are especially trained and work in multidisciplinary teams to find you the most appropriate treatment. With that, I'll hand it back to you, Eliana. Thank you very much.
Thank you very much, Dr. Amin. And now let's get rid of all this stuff and we're going to go right into the Q&A, and it's a conversation. And if there's a common theme that is coming through the Q&A box, it is confusion, trepidation, and still fear, quote unquote, of the colonoscopy. So we're bombarded on the television screen with the Cologuard commercials. So everyone keeps asking, why can't I just do the Cologuard versus the colonoscopy? Can we clarify tonight from all of you and weigh in on this? Who is the candidate? What are the guidelines? Who can have the Cologuard versus the colonoscopy, or should all of us have the colonoscopy as the absolute best measure? And then let's talk about ages. Dr. Sussman, perhaps you'd like to kick it off.
Sure, there's a lot wrapped into that. So, for starters, I'll say that there's this mantra that says that the best test for colorectal cancer screening is the one that gets done. So if there's one that a particular person prefers and they're going to actually adhere to that and carry it out and finish it, that's the one they should do. Meaning that for some people, they would prefer to do a stool test at their house. Some people would prefer to have a colonoscopy. It's best to get the one done that you're willing to do. Now, Cologuard is a great test. The people who are great candidates for it are people who are over the age of 45, who are considered average risk. Average risk basically means that they don't have a personal history of colorectal cancer, a strong family history of colorectal cancer, and they're not having symptoms that are considered warning signs for colon cancer. That would be the rectal bleeding, weight loss, iron deficiency, anemia that we mentioned earlier. It actually specifically says on the label for the Cologuard that if you have a genetic condition that causes colorectal cancer, or any of the conditions that I just mentioned, that Cologuard is not for you. The rationale there is that people who made Cologuard put a lot of effort into choosing molecular markers of cancer that the average person might get, rather than people who have genetic conditions or very strong family histories. If people do have warning signs and symptoms, colonoscopy is a test that needs to be done without question, without fail. But Cologuard is a fantastic test. It works really well. The way that it's meant to be carried out is that if you do perform the test and have a negative or normal result, that you do the test every 3 years. And if you have a positive result, which is abnormal, then you reflexively go on to have a colonoscopy to find out why there was a positive or an abnormal result. And I don't know if you remember from the picture that I showed earlier, but there were actually two little vials that I glossed over there in the picture. One was a big jug. The big jug, they actually send for a lot of molecular or gene-based tests to try to see if there's a pattern for colorectal cancer that gets picked up. And the other was a much smaller little vial that looks almost like a little nail polish kit. Or a super glue kit, and that test looks for blood in the stool. So the Cologuard test actually combines a fecal immunochemical test that looks for blood in the stool with molecular markers. And it has a very high sensitivity. It's certainly very good over time at picking up colorectal cancers, and it may pick up some colon polyps as well, but it's not yet FDA indicated for the polyp part of it.
Okay, perfect. And then as far as the genetic, who is at higher risk? There was a question that came over, said, is it an aunt or an uncle, or is it the closer relative, mother or father? And I think Ms. Silva-Smith can weigh in. Obviously, it's mother and father, right? The closer the relative.
Yes, that's a good question. Whenever we're asking about the family history, we kind of go pretty far. We go to the grandparents level and cousins, because we want to get an overall picture of what the family history looks like. But definitely the closer relative is related, the higher the risk to develop colon cancer and the higher the risk of having a genetic hereditary cancer syndrome.
Okay, Dr. Amin, I think I'm going to throw this one at you. This is a very good question. My father has various hemorrhoids and does not want to do a colonoscopy because of the pain. What can be done in this case?
That's a good question. So, I assume the question is about the preparation. Hemorrhoids can be really affected by the preparation, as you have to go to the bathroom quite often, and that can irritate your hemorrhoids. It can sometimes cause bleeding. But if it's not about that, the procedure itself, you really shouldn't feel a lot of pain. during, if any at all, you'll be asleep for the entire procedure. So, there are medications that we can give to shrink the hemorrhoids, perhaps before the colonoscopy prep, and various other kind of solutions we can come up with. So I would encourage you to have your father make an appointment with the gastroenterologist to talk a little bit about some of the creative things we can do to get him through the colonoscopy.
Yeah. Now, I mean, this is such an important conversation. So glad that you're all being so open, just like this, talking nitty gritty, because people just need to get rid of the fears, but easier said than done. Here's a question. As a recent colorectal cancer survivor, what can I do to prevent a recurrence?
So that's another good one. So I think that there's many answers to that question. Colonoscopy is really impactful in its preventive capabilities. And after people have colorectal cancer, the only test from all of the ones that we've mentioned today that should be done with a repeated basis after somebody gets colorectal cancer is a colonoscopy. And our guidelines have actually very well prescribed intervals at which colonoscopies should happen after a colorectal cancer diagnosis. And there's tremendous impact in preventing second and third colorectal cancers when people have their colonoscopies regularly after having a first colorectal cancer. In addition to that, there are lifestyle changes. We know that exercising and changing your diet and cessation of smoking are all tremendously valuable in preventing people from getting second cancers. And a large percentage of people can actually gain benefit from using aspirin to prevent another colorectal cancer in the future. It's actually pretty impressive, the degree to which aspirin can prevent second colorectal cancers when you look at groups of individuals. We don't really yet have a good marker to figure out which particular people would benefit from aspirin after a colorectal cancer diagnosis. But if you look at groups of people that take aspirin, they're much less likely to develop a second colorectal cancer over time. And then I think that I might turn over the genetic part of that conversation to Rachel, in that there's some features that we look for when people have colorectal cancer that might suggest a genetic diagnosis. And I think I'll let her weigh in a little bit on that as well.
Yeah, so in most cases, when somebody has colon cancer and the colon tumor is removed and sent to the pathology lab, there's a type of test. It's not quite a genetic test, but it's a test that is done on the tumor itself that tells us if it's more or less likely to be hereditary. So it's a screening test. It's not a diagnostic test that tells us for sure whether it's hereditary or not. But if that comes back screen positive, meaning it's likely that it's hereditary, then we would go on to offer genetic testing at that point to confirm whether that colon cancer was hereditary or not.
Okay, let me give back to Rachel this important one. Does insurance cover the genetic screening cost? And we're going to try and get through some of these quicker because I have a couple more to tee up for the group. Go ahead, Rachel.
This is a great question because a lot of people have this question when we see them in clinic. So we have specific guidelines or criteria that have to be met that are set out by national societies. The National Comprehensive Cancer Network has very specific criteria that we need to, these check boxes that we need to check off for the insurance to cover the test. And that basically means, how many people in the family have had colon cancer or related cancers and at what ages were people diagnosed. So we use that information in clinic to figure out if the patient's insurance will cover the test. If they don't cover the test, and the patient still wants to proceed with testing, usually testing is no more than $250. A lot of people also have the misconception that genetic testing is thousands of dollars out of pocket. It's no longer the case. So in many cases, insurance covers it, but even when it's not covered, it's usually under $250 or under.
Thank you. That was important to know. So clearly, medically necessary, the higher the risk, the higher the chance, the insurance. Now, here's a question that's sort of a double one. This is an 86-year-old who asked earlier today, is in excellent health, and wants to know whether he or she should get the colonoscopy for colorectal cancer. And that dovetails to this question, up to what age should people get colonoscopies?
So I can take a stab at that one. So almost everybody who's between the ages of 45 and 75 should get colorectal cancer screening. And we generally think that between the ages of 75 and 85, that answer should be individualized, and that over the age of 85, very few people would actually benefit from getting a colonoscopy. Now, I can say something very kind of morbid about that, which is that the value of colonoscopy is it gives you kind of like a little warranty for a certain number of years after the procedure to prevent against colorectal cancer. And we generally think that prevention is about 10 years worth of prevention. And if you look at the average number of years that the average person lives, that once they hit 85, most people shouldn't have further colonoscopy stuff. Again, that decision needs to be individualized, but most 85-year-olds don't need a colonoscopy.
Right. So maybe this 87-year-old who sent us the question is still running daily or something. So you're right. It's very specific and subjective. So I think the last question I'm going to tee it up for us tonight, and then some quick concluding comments, because this person took the time to send in the question. A 42-year-old man whose mother had colon cancer. So very quickly, is a CT or colonoscopy the way to examine? I'm assuming colonoscopy.
Yeah, when there's a family history of colorectal cancer, there's no question that that at this moment in time, colonoscopy is the way to go.
Okay, Dr. Amin, I'm going to ask you to start off in a quick round robin, just some thoughts for tonight for people to take home, the messages to keep in their minds. And you covered such important stuff, and that is that in most cases you don't even need the surgery. So take it from here, and then we'll wrap this up.
Yeah, no, I think one of the take homes from my part of the talk was that if you have been referred for a surgery for a polyp that is not, frankly, a cancer, you really should seek a second opinion, because there are lots of advanced techniques that can be done to perhaps save you from having that surgery. And unfortunately, a lot of polyps are still being removed surgically in the United States and all over the world that can be treated with just another colonoscopy.
Dr. Sussman?
Yeah, I think one of the major take-home points for tonight is just that the age has turned lower for colorectal cancer screening, and we no longer should be waiting until people are 50 to be telling them that a colonoscopy is needed. 45 should be that new age for the person without a family history and without risk factors, and that we also shouldn't minimize symptoms or warning signs of colorectal cancer. If there's a 35-year-old in your family that's having persistent rectal bleeding, that person shouldn't wait till he's 45 to get done. That person should get in to see a doctor soon because he has a warning sign, and that warning sign needs to be evaluated.
Yeah, but the support, and before we finish with Rachel, the CDC guidelines or the guidelines for your insurance to cover it if it's before 45 would be trickier, no?
So if somebody's having symptoms, then it's no longer considered a screening examination, then it's considered diagnostic. And then a diagnostic examination would be medically necessary and would have its own kind of financial consequences with individual insurances. Yeah, so there's a stark contrast there between screening and diagnostic stuff for symptoms.
Thank you for clarifying. And Rachel, if you could just wrap up saying the importance of, what people need to know, that there are genetic components to this.
As we know, there's genetic components to colon cancer, and I think the first step to keep in mind in that process of getting genetic testing is writing down your family history, asking for family members on both sides of the family to tell you about their cancer history, their polyp history, which most people don't talk about, but it's important to know about because that can determine if you are a good candidate for genetic testing, and then we can ultimately use that genetic test information to make sure you're being screened as well as possible.
Well, thank you. On that note, we hit the 7 o'clock on the button. We thank you, our experts from University of Miami Health, Sylvester Comprehensive Cancer Center. You are the best and the brightest in the field. And we thank you so much for giving us of your time tonight. There on your screen, everyone, for you to see to schedule an appointment for screening. There's the number 305-243-8644. Virtual appointments, in-person appointments for gastroenterology, cancer genetics test. Also call the number there on your screen. We thank you so much for taking part in this very important conversation. And we, of course, at Sylvester Comprehensive Cancer Center appreciate your interest, and we're here to care for you. Check out sylvester.org to get more information. And good night, everyone. Stay safe, stay dry if this apparent little tropical storm that's brewing somewhere, and have a great night, everyone.
Thank you.